Welcome back to another episode of HealthCap Weekly Wrap. Today we're diving into some of the most talked about stories in senior living care, from a major study validating the health benefits of senior living communities to a deep dive into how we can rethink outdated clinical practices.
We'll also walk through a refresher on Medicare signature rules. It's not the most glamorous topic, but a really important one. Then we'll unpack some nuanced findings about the COVID vaccine that have been making headlines and finish off with a practical tool from the CDC to help assess measles readiness in long-term care communities. Let's kick it off with some good news. So this first story comes from Senior Housing News, and it's about a pretty significant study by NIC, the National Investment Center for Seniors Housing and Care, partnering with NORC at the University of Chicago. The research set out to answer a key question. Does moving into a senior living community improve health outcomes compared to staying in the general population?
Right, and the short answer is yes. A strong yes, actually. What I appreciated about this study is that it looked at actual Medicare claims data. So this isn't just survey responses or anecdotal stories. It followed over 250,000 older adults and compared those who moved into senior living communities with those who remained in traditional settings.
And what they found was pretty compelling. Residents in senior living communities had higher rates of preventive care use, lower rates of emergency room visits, and even a reduced likelihood of developing advanced frailty over time. That's a big deal. Frailty is one of the most significant predictors of poor outcomes in older adults.
There were also benefits related to mental health. The study showed improved behavioral health outcomes, fewer depressive episodes, and more consistent access to supportive services. And I think we all know social isolation can really accelerate health decline, especially as people age.
Exactly, and what's really exciting here is the broader implication. This supports the argument that senior living isn't just about custodial care. It's about wellness, prevention, and proactive support. Communities that offer coordinated services, health education, and opportunities for engagement are truly reshaping aging.
It's a validation of the work our listeners do every day. This is the kind of evidence that can be shared with families, staff, and policymakers. The report came out back in September, but its relevance is only growing as we prepare for a 2026, where aging demographics will continue to climb.
All right, let's move into something a little more clinical. This next piece is from AMDA, the Society for Post-Acute and Long-Term Care Medicine, and it's their Choosing Wisely campaign update. The title is 20 Things Prescribers and Patients Should Question in Post-Acute and Long-Term Cares, and honestly, it's one of the more practical resources I've seen this year.
Yeah, this document is packed with common scenarios, things that seem routine but might not always be in the resident's best interest. One of the big recommendations is to avoid using feeding tubes in people with advanced dementia. It's still a common practice in some places, but the evidence shows it doesn't improve quality of life or outcomes, and can actually lead to complications.
Another key point they make is about the use of antipsychotics and sedatives, especially in residents with behavioral symptoms of dementia. The guidance encourages providers to pursue non-pharmacologic interventions first and to continually reassess medication use.
And I liked the emphasis on insulin management too. Specifically, the recommendation to stop using routine sliding scale insulin in long-term care residents. It's outdated, it doesn't reduce long-term complications, and it puts residents at risk for hypoglycemia.
Right. This isn't a call to do less. It's a call to be more thoughtful, to ask, why are we doing this? Is this still the right approach for this resident at this stage? And they do back it all up with citations and expert consensus. It's not just opinion, it's evidence-based practice.
There's also a strong section on antibiotic stewardship. For example, they recommend against treating asymptomatic bacteriuria, which is when bacteria is found in a urine sample, but the resident doesn't have symptoms. Overprescribing in these cases leads to resistance, which is a huge concern in communal living.
So this is a great document to bring into clinical team huddles or QAPI meetings. It can spark discussion and lead to real changes in how care is delivered. The full list is available as a PDF from paltmed.org. Highly recommend giving it a read.
Now let's talk documentation. Not everyone's favorite topic, I know, but this next story is an important refresher. We're talking about the Medicare Learning Network's guide, MLN 905364, on complying with Medicare signature requirements.
This might seem minor, but these kinds of compliance issues can cause a lot of operational headaches. If the signature on a physician order isn't legible or if it's missing entirely, Medicare can deny the claim, and those denials can add up quickly.
Exactly. So this guide walks through what's required. First, signatures must be legible and include credentials. They can be handwritten or electronic, but rubber stamps are not acceptable. That's one of the most common issues CMS flags.
The guide also explains how to fix documentation issues, like if a signature is missing from a progress note or plan of care, the provider can submit an attestation statement, essentially confirming that the services were provided and signed by them.
And if you're ever in a situation where the signature is there but hard to read, that's when a signature log comes into play. It's a simple document that matches names to signatures. Keeping one on file can really help during audits.
This guide has been around for a bit, but we're bringing it back up because we continue to hear from communities where this is tripping up claims. If you're billing Medicare, you need to know these rules cold. It's available on the CMS website, and it's worth reviewing at least once a year with your billing and clinical documentation teams.
Okay, switching topics. But staying in the healthcare lane, let's talk about a recent story from AOL News that's been making the rounds. It's about 2 observational studies exploring health outcomes after receiving multiple COVID-19 vaccine doses.
Now, before we get into the findings, let's be clear. These studies do not establish causation. They simply observed associations, and experts were very vocal in saying these results should be interpreted with caution.
That said, the first study noted an interesting pattern. People who had more COVID vaccine doses experienced fewer flu-like illnesses and whooping cough, but they had slightly higher rates of common colds. So there seems to be a shift in how respiratory infections are presenting.
The second study looked at kidney-related outcomes and found a small uptick in acute kidney injury and dialysis within a year of vaccination. But, and this is really important, those same vaccinated individuals had lower overall mortality rates.
Right. So while there may be risks that need further study, the big picture still leans heavily in favor of the benefits of vaccination. The article also pointed out that there are a lot of confounding variables like age, chronic illness, and how often people access healthcare. These factors may be skewing the data.
Another interesting point was about post-pandemic immunity patterns. The way our immune systems are responding to everyday illnesses has changed over the last few years, possibly because of the shifts in exposure and vaccination behaviors. That context is important.
So if you've got residents or families bringing up this article, it's good to be informed. We're not seeing policy changes come out of this, just a call for continued surveillance and more targeted research.
All right, for our final story today, we're looking at a really practical tool from the CDC. It's the Measles Assessment Tool for healthcare and congregate settings. It's designed to help communities evaluate their readiness for a potential measles exposure or outbreak.
This comes at a good time. We've seen sporadic measles cases pop up in several states, often tied to international travel and under-vaccinated populations. Long-term care communities, especially those with high staff turnover, really need to make sure they're covered.
The tool includes a checklist format. It helps you assess whether staff and residents have documented immunity, whether you have a process for tracking vaccinations, and whether your response plan includes isolation protocols and PPE use.
It's also a good prompt to review your signage and communication plans. If you had a measles exposure tomorrow, how would your staff be notified? How would you communicate with families and local health departments?
Exactly. The tool is simple, but it's effective. It gives your infection control team something tangible to work from. You can download it directly from the CDC's infection control section.
All right, that's going to do it for this week's HealthCap Weekly Wrap.
Thanks for sticking with us. We hope you found today's stories useful and inspiring. Don't forget, you can find links to all the articles we discussed and more in the weekly roundup on Angie's blog at healthcapusa.com/Angie's-blog.
We'll see you next week. Stay well and keep doing the important work you do every day.